It's been an excellent meeting. It's been an excellent time to get together. My first time to Saudi Arabia, and I've had nothing but a pleasurable experience, as have many of the other international speakers. Special thanks to Faisal Abdul-Akil, who's persistently came to try to get me here, and I appreciate the invitation ultimately accepted. It's been a special thanks to you, the President, to Adel Al-Katoub, the Chair of the Scientific Committee, for selecting me to come and to provide this educational experience. We've trained a lot of, as you've heard through the last day and a half, individuals that have come to the stage have come through a lot of training with myself and my colleagues at our institute in London, Canada. And it's been a pleasure to see them now populating various areas within the country and doing such excellent jobs in their own careers at their own centers and own hospitals. They were fellows at one time, and now they're colleagues, and thankfully they're lifetime friends, and I do appreciate this. In Canada, though, what friends don't do to each other is give you a topic like this at the very end of a day and a half of a scientific presentation when everybody's getting ready to fly away. And so I did take this topic, which in itself is a week long, to go through various aspects of portal hypertension. And I distilled it down really to what I think a general community gastroenterologist, hepatologist who really manages the day and day in and out of a standard cirrhotic individual. You've heard so much science and high level and forward-thinking information over the last day and a half. I'm going to just bring it backwards and find out, why we do the things we do in portal hypertension. What's some of the history of that science? And to really congratulate yourselves and pat yourselves on the back on your way home today, because you're all doing a fantastic job saving lives. What we heard earlier in the pediatric presentation is the goal of us is to not do liver transplantation, to prevent that progression of portal hypertension. And I think we're accomplishing that in various ways. So briefly, I'm going to talk a review on the pathophysiology of portal hypertension, which many of you know. It's just to say on the same page. I want to spend some time discussing the techniques of non-invasive imaging, because this is really now, I think, how we best define clinically significant portal hypertension, and review some of the treatments for portal hypertension, particularly focus on the prevention of decompensation. And yes, I'm from Canada and the furthest away, just to make sure you know we are north of America, not yet part of that country. If my topic and content doesn't engage you, I have some pictures of our vast geography, which I hope will at least entertain you for the next 15 to 20 minutes. The objectives will be to talk about the prevention of esophageal bleeding, how we do or why we do what we do for prevention of first bleeding, very briefly on the acute bleed, preventing rebleeding because of the very high mortality rate associated with that. Briefly on ascites and how that segues into hepatorenal syndrome, which is a real complex issue. And I'm not going to talk much about some of the other portal hypertensive issues just for the sake of time. Well, portal hypertension obviously is anything that increases portal pressures. These pressures create collateral vessels within the splanchnic circulation, and thus leading to entities such as esophageal varices, gastric varices, and other clinically important shunts. And the clinical complications arise in the form of bleeding, ascites, and the onset of encephalopathy. There are several structural locations that lead to portal hypertension: prehepatic, posthepatic, and intrahepatic. I'm going to focus this talk on obviously the most important or the most prevalent cause of portal hypertension, that being sinusoidal disease caused by various etiologies of cirrhosis. With cirrhosis, you get intrahepatic vasoconstriction, and that vasoconstriction leads to the splanchnic circulation adapting to vasodilation. It's this compensation that leads to an increase in cardiac output, and that further increases splanchnic inflow. And over time, this positive feedback leads to more systemic vasodilation, a drop in circulating or systemic blood pressure, and that drop in effective circulating volume then enhances the renin-angiotensin system, leading to your clinical entities such as edema and ascites. For decades, we've really talked about cirrhosis in this type of spectrum, from compensation to decompensate, and then the rapidity after there, where it's either transplant or death, because our treatments are more band-aid therapies. And the reason we want to stop that switch from a compensated individual to a decompensated is clearly because the mortality changes fairly dramatically. However, a lot of our discussions typically focus on the symptoms of a decompensated individual all the way up to transplantation, as you've heard through this meeting. And so we really want to focus on that journey of portal hypertension from its early stages to the more advanced stages and how we can impact that. The gold standard of mapping out portal hypertension remains hepatic venous wedge pressure. This is obviously not a dichotomous variable, but continuous, and we've defined normality as less than 5 millimeters of mercury, mild portal hypertension as those that have 6 to 9 millimeters of mercury, and then above that is clinically significant portal hypertension. Values over 10 where the onset of ascites can occur, and certainly over 12 where the onset of variceal bleeding and the mortality associated with that is higher, and higher thereafter proportionally with higher values. I'm going to hit some of the practice guidelines that have come out approximately 2 years ago on portal hypertension. A lot of it is some definition changes and really conceptual changes. One of the main conceptions is trying to get away from the word cirrhosis, which I don't think we will, or I certainly won't after doing it for 30 years, into more of a compensated advanced chronic liver disease. This is particularly because cirrhosis has always been linked to a histologic diagnosis, and as you've heard again through the meeting, our number of histologic examinations these days is far fewer. I'm going to talk about the non-invasive assessments that we can use to identify clinically significant portal hypertension and how that knowledge should impact our treatment moving forward. I'm going to talk about beta blocker therapy just because of the evolution of that over the last several decades to accomplish what we've accomplished in the clinical setting. In the past, to define cirrhosis, we've used a lot of our clinical things, thrombocytopenia in terms of some lab testing, various imaging modalities, ultrasound, CT, MRI, looking for things like splenomegaly, early ascites, or collaterals. Even endoscopy in almost all cirrhotics at one point, to look for moderate to a larger size varices. All of these things occur very late in the portal hypertension spectrum. And when we find them or if we use them for diagnoses, I think we're missing the boat. And nowadays with non-invasive testing, particularly FibroScan or equivalent, I think we can find portal hypertension at an earlier stage and intervene. This is an example of defining clinically significant portal hypertension by transient elastography. It's a retrospective analysis over 800 individuals, all with cirrhosis, all with hepatic venous wedge pressures greater than 10. And the correlation here is that liver stiffness scores greater than 25 kPa correlate very well to those with clinically significant portal hypertension. And perhaps more importantly is the negative predictive value. That being liver stiffness less than 15 kPa really excludes clinically significant portal hypertension. And so cirrhosis, which was once, will always be a histologic diagnosis, but we don't do liver biopsies much anymore. Liver stiffness measurements can now predict various levels of fibrosis, and I think moving forward, they can predict various levels of portal hypertension. We look at individuals by liver stiffness scores and their risk of decompensation or death. And obviously on the low end of the scale, there are individuals between 10 to 15 kPa on liver stiffness measurements, which should be considered to be followed, ideally intervention if depending on their liver disease to try to prevent them from progressing to those that have a higher risk of decompensation. We've typically focused our discussions on the far right aspect of this slide, whereas individuals with high liver stiffness or clinically significant portal hypertension typically get all the recognition because they're the ones that have ascites and variceal and the onset of encephalopathy, the need for transplant, et cetera, et cetera. And I think it's this middle group between 10 to 20 kPa that I think deserves a little more input in terms of prevention of that journey through the decompensated state. Transient elastography has permeated itself into our clinical pathways. This is just an example showing once again that KPAs be greater than 20 to 25. I think you might perform upper endoscopy to look for moderate to higher size varices for interaction. And again, the negative predictive value seems to be more important, that those with lesser values of liver stiffness, really you won't find moderate or higher size esophageal varices, and there's no need to do upper endoscopy. This upset our local gastroenterologists because they're very interested in doing upper endoscopies routinely. but it also represents the vast majority of cirrhotic individuals. So you're saving a lot of time and effort for an item that you will not find. And so once again, we've used this paradigm of looking at individuals and trying to prevent that compensated state, those with perhaps mild portal hypertension, to progressing to one of the symptoms, because that starts the slippery slope all the way to death or transplant. And I think non-invasive testing can identify these patients much earlier and provide these treatments. And suffice it to say, I think even very early on, where this new X is, this graph doesn't represent what is proportional to the number of individuals that reside in this little block. That is cirrhosis, but without or with very early mild portal hypertension. This is the vast majority of patients in our clinics. Perhaps not at our tertiary clinics because they're getting referred for a specific reason, but out in the community. And what I see with a lot of my patients with early cirrhosis is you're going to die with cirrhosis, not because of cirrhosis. That's true to a lot of people, but not true for some. And our goal, I think, is to keep that in almost everybody. Well, how can we do this? I showed you, if you're bored by now, I'll show you some real exciting content about some pictures in Canada. So this, like your capital, this is the capital of Canada. This is Ottawa, population about 1 million people. And this is where our Prime Minister governs. And it's a pretty city with lots of tributaries and river systems through it. We can impact portal hypertension or liver disease by directing treatments toward liver-specific therapies like viral cure, alcohol cessation, and then there's some general therapies, of course, with beta blockade and statins, which I'll discuss. This is an example of a liver-specific therapy. This is a group of hepatitis C patients, all with portal hypertension, wedge pressures greater than 10 millimeters of mercury, all successfully treated with direct-acting antiviral therapies and then followed with wedge pressure measurements up towards 2 years. And what you may see here is that at least half of these individuals, their portal hypertension regresses to values less than 10 millimeters of mercury, meaning their incidence and their likelihood of progression towards a decompensated state is much, much less. And so this architectural change within the splanchnic circulation does happen with liver-specific therapy. We've heard it yesterday from Sven, who talked about weight loss in the metabolic syndromes, and there's evidence that portal hypertension also decreases by a minimum of 2 millimeters of mercury. And then we focus on more general therapies, beta blockade and statins. There's a long history in the evolution of beta blocker, really how they've come to light in treating prevention of variceal hemorrhage. I'm going to talk briefly on this area because beta blockade is one of the main institutes that we can accomplish with engaging our cirrhotics. Variceal hemorrhage prevented by prophylactic therapy with beta blockade, as well as mechanical therapies, band ligation. This is an important outcome because of the very high mortality rate associated with variceal hemorrhage. Certainly in those individuals with liver stiffness scores greater than 25 kPa or advanced portal hypertension, the rate of variceal bleeding is high. Each bleed comes with a specific, an equally high mortality rate, and up to 1 year, that rebleeding and mortality rate is quite high. And traditionally, we've used beta blockers, propanolol, and then nadolol, and more recently, and over the last few decades, in countries that have had this carvedilol, it's become really the agent of choice, particularly because of its alpha blockade therapy and the intrahepatic vasodilation and reduction and resistance that occurs with that. Lowering hepatic pressure gradients with non-selective beta blocker certainly reduces the risk of variceal hemorrhage. The goal is to reduce pressures to less than 12 milliliters of mercury, or at least a 20% reduction from baseline. With the traditional beta blockades, propanolol and nadolol, initially we were titrating this to heart rate towards 50 and 60. However, that was more for tolerability, not necessarily because of the hemodynamic effects. And meta-analyses have now shown that beta blocker, just targeting to a 25% reduction in heart rate, really accomplishes what we need it to do in terms of reducing rebleeding and reducing the fatality associated with bleeding. Well, this is an example of knowing that beta blockade really is not effective in a large number of people. About 60 to 70% of patients that are given traditional beta blockade response. This is a study where pressure measurements invasively were done at the time of initialization of propanolol and then followed up several months later. And in red text, you can see that about 70% of individuals responded correctly hemodynamically to the introduction of beta blocker. And those individuals typically responded down the road many months later. The group that did not respond, though, if you were a non-responder initially, you did not respond later. Unfortunately, we don't do invasive measures at the time that we start beta blocker. So we're treating 100% of people to get no more than 60% of people to respond, not knowing who they are. And then when you factor in tolerability of these agents, you're really treating less than 50% accurate. And I would say that's a very inefficient use of a pharmacologic product. Enter carvedilol. Well, carvedilol has been much more effective at lowering pressure gradients, more so than propranolol. In addition, it's a much easier dosing strategy, and there's no really need to titrate it to heart rate. And so carvedilol has become the recommended first-line therapy to prevent first variceal hemorrhage. It's also associated with lower all-cause mortality. This is a study using carvedilol versus van ligation in the prevention of bleeding. However, in the long term, not only was bleeding prevented, or at least was similar, in long term, the overall mortality was different, favoring beta blockade, favoring the carvedilol group. This suggests that it has more effect, obviously, than just prevention of bleeding. It's also associated with an overall decrease in decompensated disease. This is also an interesting study in Spain, about 210 patients, all with clinically significant portal hypertension documented with pressure gradients greater than 10 millimeters of mercury, but no patient had a prior decompensated event. And very few of these individuals had endoscopically large varices that would require initial therapy. This is typically a group that we would not provide prophylactic therapy to, or at least we'd think about it. And wedge pressure measurements were done. These patients were started on propranolol, and if they failed, carvedilol. The bottom line is the episodes of decompensation and liver-related mortality was decreased more in favor of the beta blocker group. This was not driven by the episodes of variceal bleeding. This was actually driven by the development of ascites. And so this is a group that it typically had not been a group that we would target for prophylaxis. And I think this is targeting them earlier on in that journey of portal hypertension. So beta blocker therapy, we know, reduces the risk of first bleed. We're aiming for a pressure gradient drop of at least 10% and to a reduction of gradient to less than 12 millimeters of mercury in total. Carvedilol has most of the advantages, no need to titrate it, fixed dose, larger increase or decrease rather in portal hypertension, the gradient, and does reduce all-cause mortality. I think the question more is, so when do we apply these agents? Clearly over 25 kPa by liver stiffness, but this early group, 10 to 15, 15 to 20, I think there's evidence that it decreases that introduction into portal hypertension. I'm going to switch gears to one slide on the acute variceal management. This is a picture of Western Canada in the wintertime, which can be pretty. The one slide is only, a lot of this information is not very new. Our transfusion strategies following trauma really try to get hemoglobins above 7 or 70, try to avoid extra product transfusion with FFP and platelets, the introduction of octreotide early because of its benefit and early overall mortality, antibiotic initiation to prevent SBP, and urgent endoscopy within 12 hours. These are very standard, certainly in our institute and other large institutes. What is difficult is with our geography, and I think with other groups, those that reside in the community and in rural settings, some of these are very difficult. Getting an endoscopy within 12 hours from where we live, within several, it just does not happen. Even the introduction of antibiotics. So this is just a call out to just education, right? We need to educate our peripheral caregivers to do things like this, urgent endoscopy, why it's important, introduction of antibiotics, et cetera. Because we all do it, and we sound this is very easy and straightforward, but it is not for everybody. I'm coming back to winter because it's only 4 to 6 months long, and so you should enjoy a couple more pictures of it. When I fly back, I think we're getting right into the winter season very near, so I'm getting my shovel out. Prevention of rebleeding remains to be a combination therapy with beta blockade and van ligation. The combination therapy is better than either one alone. And again, the issue here is that the band ligation protocol or strategy is to ban until eradication, and that's typically every 2 to 4 weeks, which again, in our institutes is easy to coordinate, but out in the community and in more rural areas, getting endoscopy at that type of 2 to 4 week type of protocol is sometimes quite challenging. In this aspect of preventing rebleeding, carvedilol also is the lead beta blocker of choice, particularly because of all the previous findings, the reduction in portal gradient, the reduction of rebleeding, and overall liver-related mortality that's decreased. What's moving forward perhaps in this variceal bleed group is the introduction of an early or preemptive TIPS consideration. This was discussed in the fellows course a day and a half ago, in that there is a select population that after control of rebleeding, they may benefit from a TIPS insertion. This is a study looking at standard of care for individuals with bleeding, giving beta blocker and band ligation, versus providing early TIPS, typically within 72 hours of the index bleed, showing obviously free from bleeding because of the reduction in portal hypertension, but also an improved overall survival. And so in high-risk patients, those typically child's B or C or mALDs above 18, this is something, if your institute offers it, should be considered, and we should probably be more evolving into that. This is just a schematic representing the same idea that after the bleed has occurred, if you identified this group as someone with a child's B or C or with pressure gradients greater than 20, that they should be considered for TIPS if they're eligible for such and or for transplantation because of the rebleeding risk that enhances their mortality rate substantially. I'm going to talk about the evolving role of statins in portal hypertension. Statins have many different areas of effect. They might mitigate some of the structural and the functional changes that occur in portal hypertension. There's evidence of decreased collagen production. There's evidence of decreased vascular resistance. And so along this whole pathway of early to advanced portal hypertension, there may be some influence. This is a series of meta-analyses put together that show that statins may prevent decompensation and death. There's evidence that they decrease the risk of progression in portal hypertension, that exposure to it decreases the risk of decompensated liver disease, and that exposure can decrease the risk of all-cause mortality. There's a larger study out of the U.S., a large VA cohort of over 80,000 individuals, where statins were used and were associated with the similar issue of a decrease in acute on chronic liver failure. Not only that, but the graphs separate by dose and duration. The higher the dose you were on, the longer duration, that benefit was enhanced. I'm going to move to hepatorenal syndrome. Hepatorenal syndrome, what's changed is really the definition. And the definition has changed really to provide perhaps an earlier introduction and earlier intervention. Creatinine values by a slight increase over a shorter time frame, meaning less than 48 hours. And that earlier diagnosis can allow for various molecules to be tried and to prevent the worsening of this condition, which ultimately is high mortality, certainly in those that require renal replacement therapy as well. And it's typically driven by hypovolemia and vasodilation. Treatment remains volume expansion and vasoconstriction because we know that the effects of these things increase systemic pressure and decrease the renin-angiotensin system, ideally leading to an ultimate increase in renal perfusion pressure. There have been several molecules used over time. The norepinephrine obviously in the previous era just because of the high cardiac toxicity. We've been exposed mostly to midodrine and octreotide at our institute. We do not have terlipressin, and it's been evolving in various countries. And Europe has had it for much longer, and the U.S., I think, in the last 2 years had FDA approval. But it's become the drug of choice in this condition and provided earlier. This is evidence showing that early treatment with terlipressin leads to a higher incidence of reversal of hepatorenal syndrome and a less need for renal replacement therapies. I'm going to summarize. I know everyone has somewhere to get to. So in general, one of the newer aspects, I think, in the journey of portal hypertension is really trying to identify it early. I think non-invasive metrics that we now have access to can define this condition. And that may allow us to provide much earlier engagement in our cohort prior to waiting for a decompensated event. I think our liver stiffness values are evolving and becoming more accurate, but certainly less than 10 to 15 millimeters of mercury or kPa will exclude clinically significant portal hypertension where you do not need upper endoscopy. But perhaps in that 15 to 20 prior to the onset of portal hypertension, there may be a role for beta blocker therapy such as carvedilol. Certainly for those individuals with much higher liver stiffness, that's a guarantee. Preventing of rebleeding remains band ligation with beta blocker therapy, and the evolution of a early use of TIPS, I think, should be considered in those high-risk populations. There's evolving evidence that statin use perhaps can be suggested in all individuals with cirrhosis for some indirect evidence that support decrease in overall mortality. And hepatorenal syndrome remains probably one of the more complex areas of decompensated liver disease with quite a challenge. And however, early recognition, change of the definition has helped, and early introduction of agents such as terlipressin can certainly reverse this. And I think that is how I will end my discussions, and I thank you very much for your attention.